Hi, I'm Chiadi Ndumele. I'm at Johns Hopkins University, and I'm the chair of the new AHA, ACC, ADA, ASN Cardiovascular Kidney Metabolic, or CKM syndrome clinical practice guideline. I'm joined by my vice chair.
Very delighted to be here. My name is Fatima Rodriguez, and I'm the vice chair of this guideline, working closely with a really wonderful group of volunteers across these different specialties.
Oh, it is a pleasure to have had the opportunity to work with Fatima and this amazing group. So, the first question is, why are we working on this at all? So, what is the issue and the need for a CKM syndrome clinical practice guideline? So, first, as many of you are aware, CKM syndrome really is a major and growing clinical and public health challenge. It reflects the fact that we have these close interrelationships among metabolic risk factors, things like obesity and diabetes, with chronic kidney disease and the cardiovascular system. And because of the obesity epidemic and related rises in diabetes and chronic kidney disease, this is really becoming the predominant form of cardiovascular disease risk in the population. And it's actually not only driving increased risk and early mortality, it's also driving health disparities because we see the burden of CKM syndrome disproportionately distributed within the population. And because we have a lot of multi-system disease as a part of CKM syndrome, people from multiple specialties are often involved in care, and fragmented care is often a major challenge. So there's a lot of urgency and concern around this, but there's also a lot of opportunities. So opportunities include the fact that we have a much better understanding of the underlying science. It allows us to target this CKM syndrome multiplex at earlier stages to prevent progression along this spectrum of disease and also to promote regression as well. We also have increasingly effective ways to support healthy lifestyle and to facilitate coordinated care. And we also have new approaches to cardiovascular disease prediction that can incorporate measures of CKM health as we're trying to understand short and long term risk. And finally, we have increasingly effective therapies that have multi system benefits that can improve both cardiovascular and kidney outcomes in this CKM syndrome population. So, a lot of urgency, but also a lot of opportunity. So, Fatima, I'm going to ask you, what were we trying to accomplish? What was the purpose of this clinical guideline?
Well, thank you. I think you said it really well, and I'll just simplify by saying we were trying to provide a unified framework for all of us, who sit in our different specialties like cardiology, nephrology, endocrinology, to think about this CKM process in a more unified way. We had several objectives. So we wanted to make a really practical, evidence based guideline with really expertise from all disciplines. And the first was really to have a new way to evaluate risk. How do we reframe risk assessment? Like you mentioned, there's new ways to do so with a particular focus on the prevent equation. We also wanted to promote earlier intervention and focus again on the use of these novel therapies, but also lifestyle. And finally, we were emphasizing throughout the guideline the need for unified, holistic, coordinated care because patients can enter the CKM framework, or really individuals, at any stage of the continuum.
I think that that's wonderfully said, Fatima. And I think that leads us nicely into thinking about what some of the top 2 to 3 messages might be for clinicians and researchers from the this guideline. So I'll start with number one, and that really reflects some of the first point you raised, which is about how we think about evaluating risk. And I think this is important because it's often the case that people in the CKM syndrome spectrum are initially quite asymptomatic, and by the time they're recognized, they usually have very complex presentations, and that is often associated with worse clinical outcomes. So we want to identify people in a more timely fashion. So this involves more routine testing for metabolic risk factors, as well as for chronic kidney disease. And for chronic kidney disease, there's an emphasis on both EGFR and UACR as well to really kind of get that complementary information about kidney disease risk. There's also a focus more broadly in assessing social determinants of health because we know that the social context is very important to how we're thinking about risk in the context of CKM syndrome. Fatima has already mentioned the prevent estimation, and that's not only important for kind of quantifying where people are on the risk spectrum, but also really helpful for guiding some of our diagnostic strategies and our therapeutic strategies as well. And I think that's a key emphasis in the guideline. And then finally, CKM staging, which brings a lot of these different pieces together with a focus on life course prevention. So it's indicated for both youth and adults, so we can identify people at the earliest stages and really try to arrest that progression to those later stages of CKM syndrome, particularly to cardiovascular disease, kidney failure, and early mortality. Fatima, what's another take home point you might emphasize?
I think another key take home point is to address the interrelated factors of obesity, diabetes, and CKD really holistically. And that's through, of course, lifestyle support at the framework of everything, collective control of CKM risk factors. And again, we have these new therapies, growing evidence, changing rapidly. And we really took a critical lens on the evidence for these tools that we have. Now we have SGLT2s, GLP-1s, non-steroidal MRAs as some example. And we try to be very specific and clear on how to best use these therapies across the CKM spectrum with a focus again on prevention of advanced CKM stages. And then I'll just add that finally, and really important theme across this framework is to support coordinated care, emphasize on team based care, use of CKM coordinators, addressing holistically not just the clinical challenges, but also the social determinants of health, which impact the care of our patients.
Well, thank you for that, Fatima. And I think that those are some really great take homes from early take homes from this. But we really do also want to spend some time thanking the folks that contributed to this important document. So, our writing group. And this includes our really amazing multidisciplinary group of volunteers from various perspectives: primary care. We had pediatric representation here. We had not only internal medicine, but also cardiology, endocrinology, nephrology. We had pharmacists and nurses, and we also had some really great patient advocates as well. And they had representation not only from the American Heart Association, American College of Cardiology, but also from the American Diabetes Association and the American Society of Nephrology. So really a great multidisciplinary perspective provided here that made this document so much more rich.
And we encourage everyone to click on the QR code and read the guideline and really start with the top messages, because those are really things that we think are helpful in everyday practice. And then read the sections and the evidence base on areas that are of most interest. And finally, I really want to thank the chair of this guideline, my colleague, my friend, Dr. Ndumele, who really brought us together. I learned so much, and I hope all of you will learn so much too in reading this guideline in support of our patients.
Well, it was an absolute honor to work with you, Fatima, and with the entire writing group. Thank you all for listening, and we look forward to you reviewing the guideline.